absolute contraindication to
This
rotablation.
meeting is being recorded.
So, that I said that no, it's not always a contraindication. Sometimes rotablation can get you out of trouble with dissection. And slowly the scope of the talk expanded to include perforations as well because it was felt that this one case was too much, although I thought it was a very nice case. But still, let's see what we can make of it. So the story starts with a 63-year-old male, hypertensive, who presented with crescendo angina with a creatinine clearance of 42 ml per minute, normal LV function. He had a normal dominant RCA, but the left system showed an ostial proximal 70% disease in the LED. We'll just see it in the next cine. The ostium of the circumflex appeared healthy, but the superior division of an early OM had significant disease. But he was planned for an LMLED crossover stenting. And this is what the angiogram showed. You can see that there is a subtotal occlusion of the proximal LAD and a little bit of calcium that you can see above the distal left main in the caudal view, although this is an AP caudal. And the operator thought this is not a problem and we will do an LMLED crossover. We were actually doing a study on how a single stent strategy would do in an osteoartery disease where there was no left main disease, and he was recruited for the trial. And after inclusion and all the requisite permissions and consent, he was taken up. It was planned for, as I said, an LMLED crossover. So wires were placed both into the circumflex, that is the early OM, and the inferior division of the OM, the non-diseased version, and the LAD. And an initial balloon dilatation was done. It was dilated well. This is a 2 millimeter balloon, which had no problems in crossing and dilated. But the stent wouldn't pass. So a little more dilatation was done with a slightly bigger balloon, 2.5 balloon, but the stent is still not going. And now you can see that a little bit of dissection has emerged, which seems to be progressing rather backwards as well. And it's got the ostium of the circumflex is also now inward. So another dilatation was attempted, but this is what then occurred. This is now big trouble, a large dissection, which is now extended into the circumflex as well, and a subtotal occlusion almost to the circumflex, and TIMI1 to TIMI2 flow in the LAD as well. Big trouble. And so the alarm bells were rung, and we were called in to see what we could do to salvage the situation now. So initially, first anesthesia was called, an IBP was inserted, inotropes were started. Now, what do we do next? Do we send the patient for surgery? Do we try an anchoring balloon in the circumflex to try and finish with the LAD? The option that we chose was rotablation. We've always been taught that dissection is a contraindication for rotablation, and I chose the most extreme example. This is an almost completely occluded LAD. It is very, very badly dissected, and the dissection doesn't get any worse than this. But it was felt that it was the calcium that was preventing anything from going across. And the other problem with the rotablation was that we would lose access to the circumflex because you have to pull the circumflex wire out. Anyway, that was a decision that was made, and we were confident that we'd get through because we've done some cases like this earlier. As I said, I chose the most extreme example. So a long balloon and a cutting balloon inflation were tried, but they also didn't succeed. The stent couldn't still be negotiated. The Corsair just had a lot of difficulty in going, but finally we could negotiate the Corsair through the proximal LED part from the left main into the LED, and the rota wire was positioned. It's only after the rota wire was positioned in the distal LED through the microcatheter, and we managed to take the burr up to the ostium of the left main, that we actually pulled out the circumflex wire because we still had other options to back up in case this didn't work. But once we were able to do that, we burred through the distal left main into the proximal LED without much of a problem. We managed to finish the rotablation. The Corsair, as you can see now, this time has absolutely no problem in going across into the mid to distal LED. Both the LED and the circumflex were wired, and we finished with the DK crush. This is the first stent after preparation into the LCX OM. The LCX stent is crushed with the LED balloon. The LMLED crossover stent is placed. The pot is done, and that's the final kiss down. I've just shown it in short. Basically, the message being that there is no problem as far as doing a rotablation and a dissection is concerned, as long as you don't lose access to the distal vessel beyond the dissection. Now, this was stent boost, and that's the final shot. And the patient recovered completely. You can see the heart rate was responded. The IBP was removed on the table, and he was being shifted out. This is the sequence of events. But when trouble comes, it doesn't come alone. And in all this is what the final result was as far as the coronary was concerned. It looks very good. Are we done? No, there was a major problem there. In 10 minutes, the patient developed severe hypertension. We did a quick check angiogram. Everything was fine. We did an echo, normal, LV function was normal. There was no pericardial effusion. What next? We looked at the bladder, and this is what the bladder was like. And this is one of the freak anatomies in which, although the puncture is infrainguinal, one vessel actually runs through the femoral sheath and goes upwards and leaks into the retroperitoneum. Now, once we made this diagnosis with the DSA, it was a fairly simple matter. We closed with a crossover sheath, we kept a wire access and then closed this right femoral artery access with an angioceal vascular closure device, inflated a balloon across where the leak was beginning and left it alone for about 10-15 minutes. And after 30 minutes, the leak completely sealed. We didn't deflate the balloon till then. Two DSAs, 5 minutes apart, without the balloon, showed absolutely no residual leak, and the patient could happily be taken off the table. So the lessons to be learned is important thing is to plan ahead. Even if one is doing a left main, wherever possible, take a 7 French guide. Wherever possible with calcium, always have a 7 French guide. Identify the problem. Never underestimate the calcium. The combination of calcium with a bend can sometimes make one's life very miserable. Even if you have a support guide and you have an anchoring balloon, sometimes it's a little difficult to get hardware across. Rotablation is a must in any lab if there's any kind of calcium. Ideally, imaging gives us a lot of help, but on that particular day, imaging was not available. And hypotension must be approached systematically with a cool head. You just look at what you've done with the coronaries, look at the heart, look at the pericardium, look for any retroperitoneal hematoma. If that doesn't occur, look at the IVC size. If it's small, then we're looking at a bleed somewhere else. Try and localize where the bleed is and try and close it off. That was the first part of my presentation, and I should be glad to stop here and answer any questions if anybody has any issues as far as rotablation in dissection is concerned. So shall we go to the second part and then come back here? Saujatya, I think you're muted.
Sorry, sir. Sir, I was just asking that in left main or osteal-LAD lesions, should imaging be used liberally? So maybe we can identify spots or calcium or things like
Definitely.
that.
Yeah, I said right in the beginning, ideally, every patient who is undergoing a left main, a bifurcation, or a calcified lesion angioplasty must undergo imaging. I chose this example. This is about a 4.5-year-old case. Just to answer the question that dissection is a contraindication to rota, it is not. It can be done if you are careful and you follow the basic principles. It can be done. It is not a contraindication. Do not fear rotablation in a dissected situation. But if in today's world, it is you must image wherever possible.
So, sir, what is it that we should be prepared for in case we are doing a rotablation in dissection?
So
What are
the
the
most
things we must
important
have?
thing, yeah. So the most important thing is every wire exchange must be over a microcatheter. Never ever become confident that no, I'm sure I'll be able to wire it. There's no problem. I'll pull the wire out and put another wire beside it. That is a recipe for disaster. Every single wire exchange must be over a microcatheter. If possible, if you need access to a side branch, use a dual lumen microcatheter, but never ever try to exchange the wire, trying to put one beside it. Some people sometimes take a shortcut. You finish with the rota, you want to put a workhorse wire beside it and pull out the rota wire. That should never be done. Every single wire exchange should be over the microcatheter. Secondly, ensure that you are deeply in beyond the dissected segment into the true lumen whenever you have your wire and whatever hardware you're taking across. Because if it flips back or gets caught on something, then you're very badly stuck. They seem like very basic tips, but they're extremely important and they will get you out of trouble and prevent you from getting into trouble in the first place.
So there was a possibility, I mean, as you suggested, of the dissection extending into the circumflex, but you did lose out the wire in order to, rotablate the LAD. So that would have been a disaster if we had a complete collapse of circumflex.
So we are over 500 rotablations old now over the last 15 years. And in only 2 cases of those 500 have we lost the side branch. It can occur, but it never does. Because when you're using the rotablation, you're actually creating much more space. Even if you transiently lose it, it is much easier to wire into the side branch after a rotablation than to try and do something before. So it is a fear, like dissection is a contraindication to rota, but it doesn't actually occur.
The third thing is that there is a risk of perforation. Now, in case that happens prior to the modification of the calcific plaque, getting across a graft stent would be much more difficult than, as you said, a normal stent itself was not passing. So then what would we do in such a scenario?
So I would actually finish the rota and then deliver the graft stent.
Okay.
So you don't stop the rota, you finish the rota and then deliver your graft stent. Because I assume your question is the perforation has occurred in a calcified lesion.
Yeah.
You have not yet done the rota. I'm
Yeah.
assuming that you have prepared for a rota.
Yes.
If you have prepared for a rota, then it's a fairly simple matter to put a microcatheter, finish with the rotablation, put in a balloon, turn around, talk to your friend, say hello, good morning, good afternoon, good evening, then turn back and then deliver your graft stent after that. That is what I would recommend. But it is a ghastly situation to have a perforation in a situation where your hardware is not going across. Usually this occurs when somebody tries to do a high pressure balloon inflation without having prepared the bed properly, without delivering a cutting, without doing a rota. You try to do a high pressure balloon inflation. Typically the calcium cracks at the edge and the junction
Yeah.
between the calcified part and the normal part. The spicule of calcium perforates and kind of damages the vessel enough to cause a free perforation. I'm going to try and show that in the subsequent presentation. But it is a very bad situation. If you have not already, if you have prepared it, it is a fairly simple matter to go in and put in a graft master. And I encourage everybody to try and steal some papyruses and keep one or two with you in your lab if possible, because it is a much more friendly stent and it will go anywhere. I will also show you a situation where the graft master was not available and what we did to get out of a large vessel perforation. So that might help you in a desperate situation sometimes.
Okay, sir.
Is there need?
Dr. Swami, in case I, I may ask, Dr. Swami.
Please go ahead, sir. Please go ahead.
Now here you showed a case where you did a rota when first you had a dissection, then you did a rota.
That's
What
right.
about a vessel? What about a vessel where if it is a dissected coronary with a calcification where your wire is not inside? Would you still go ahead try to wire it and then rota it, or you leave it alone? What would it be?
Sir, I think situations must be managed individually. We cannot have one rule for all. In any dissection, if your wire has come out, you are in deep trouble. You and your patient both are in deep trouble. Your first aim must be to get the wire distal. If you are confident that your wire reaches distal and you're sure that your hardware is not going because of calcium, then I don't see any contraindication to doing a rotablation. That was the point I wanted to make. But however, getting a wire across a dissected segment is sometimes a little difficult and a little challenging. You must have enough experience with different kinds of wires that sometimes you have to step down or you have to step up. And it's important to have all the wires from SUO3 to Gaia 3 to try and get into the true lumen. And sometimes you use a softer wire, and sometimes you treat it like a CTO and use a hard wire and get to the true lumen. So you may go true, false, true, and you may create a small perforation, but at least you will be in control of the situation. That would be my answer. I cannot give you a single answer for all. There are certain segments which are very, very dangerous to cross with a rota if you're not sure you're always in the true lumen, like the circumflex, which is a very, very troublesome vessel, the C of the RCA, or any double bend beyond which it is sometimes difficult to take a rota without compromising safety. Those are special situations, and you just can't apply one rule to all.
Good evening, sir. It was a wonderful case. My question is, sir, previously we used to ask to do the fast peaking movements, but I am not a very good in rota. I have done around 15 rotas, 15, 20 rotas, and I used to do slow peaking movements, and most of the time they did it well. So what is your opinion about the fast peaking versus slow peaking movements in rota ablation?
So there are basically two steps in rota. One is peck and the second is polish. The peck part is fast or slow depending on how severe your stenosis is and how angulated your vessel is. If the vessel is straight, whether you do a fast or a slow peck, as long as you cross, it doesn't really matter so much. The problem is only when you have a greater than 45-degree bend, in which case, if you are very, very fast and go through, your burr might get entrapped. This is different from a stalled burr. This might be a trapped burr, in which case there are a lot of problems that you have to encounter before getting it out, and that is a whole different discussion. In that case, I would actually do a very, very, very slow peck. The fast peck, or which people just touch and come back, touch and come back. I have speeded up the videos in which I do, which I have shown here, just to try and have a little more discussion.
Okay, sir.
But I suppose it looked extremely fast. We're not usually that quick, and that is only done in case you're really scared of the burr getting entrapped.
Okay, thank you, sir.
Right.
Right. So I think Dr. Saujatya has put up a question as to whether there is a preference of extra stiff wire versus a normal wire in case of such ostial calcified LED lesions. So is it, are we taking the extra stiff wire for extra support, or are we taking it only to change the bias? So I think there is a question about that.
I mean, it's a great
Yeah,
question, and
sometimes when
there
you take
is
the rota and it keeps jumping out the guide in such proximal calcified lesions. So um, maybe we would like to, and we can't jam the catheter in too well. So is there a difference in using the two types of wire?
yeah, there is an important difference. If you have got a straight segment, whether you take a soft or a very hard wire, your
Mhm.
burr has got to cross. It doesn't matter so much. The problem is only when there is an angulation. Now, in this particular patient, we had a fairly straight segment. It was angulated in the iliocaudal, but it wasn't so bad. It was not like a 90-degree or an 80-degree angulation. So we took a stiff wire because we wanted support for our rota wire to cross. That's why we took a more supportive wire. But otherwise, if it is angulated, I would be very scared to take a stiff wire because then the burr sometimes biases itself separately. And sometimes when you have eccentric calcium, a strategy we often follow is to do burr once, then put in a cutting balloon, cut with the balloon, change the bias, and then go back in with the rota burr again. I think that's the best option for an eccentric calcified nodule or an eccentric calcium which doesn't heal, because otherwise the balloon will keep on dilating on the normal side, and you end up with a very eccentric stent with poor MLAs. So that's one of the strategies that we use. That we change the wire bias by using the properties of the wire and by using a cutting balloon halfway through. So that's again to emphasize that basically dissection is not a contraindication to rotablation.
Sir, is there a difference in Diamondback versus this rotablation in type 3 dissections?
I don't know that actually I have no experience with Diamondback, but
No,
I
it's a
do know.
theoretical
Yeah, but I do
question.
know that I mean I was reading on Twitter a thread by one Dr. Kaushik who works in the US, and he says he's done a lot of work with Diamondback, and he said I switched to Diamondback and now I have switched back to Rota, because the ability of the rotor to get through a very narrow segment is far in excess. In Diamondback, the whole system has to cross the lesion before you actually start ablating. So that is a little bit of an issue, which doesn't happen in the kind of lesions that we are used to doing. Our burr has to cross before anything else enters. The only problem is the place where the Diamondback scores over rota is eccentric calcium, because you are very much dependent on wire bias to actually ablate the calcium, and that is sometimes a challenge with rota, although you have to find a way around it, change your wire, use a cutting balloon, whatever. But there the Diamondback is slightly better.
Thank you, sir.
So with the permission of the house, I'll move on to the next. Anybody who's missed, we can always come back to this case. This is a little short presentation on predictors of perforation and anticipation. So this is the story of one 68-year-old male who's taken up for an angioplasty to the mid LAD. You can see there's quite a bit of calcium on the left prior to the contrast coming in. I don't know if it's visible on your screens, but the proximal LAD is quite heavily calcified. There's tram track calcium. And the mid LAD has got some calcium as well, but not so bad. And it was thought that this can be easily tackled. So after putting in a balloon, we felt it was prepared adequately, and two-stent strategy was going to be followed. The distal stent was inflated and optimized. The same stent balloon was pulled back and dilated at little high pressure because it was felt that the distal half of the stent had not expanded properly. And this is what was the next shot. This is the second case, a 58-year-old hypertensive ex-smoker, chronic stable angina with recent worsening crescendo angina, but normal LV function. He had two tandem lesions in the LAD, 90% discrete with a post-stenotic dilatation with a large diagonal from this diseased segment, and a 1-1-1 Medina bifurcation with this diagonal into the distal LAD, and a small plaque distal to this diseased segment that was imaged in two views. The wires were crossed, the diagonal was protected, and the distal stent was inflated after a balloon preparation, but the distal stent appeared incompletely expanded. So the stent balloon was pulled back and post-dilated, as you can see on the screen on the right side between the left and the right. The stent balloon has been pulled back. It appears that it is expanded well, but the next angiogram shows this. So coronary artery perforation is a rupture of the arterial lumen, resulting in a leakage of its contents, which is caused by guide wires, atherotomes, directional rotational atherectomies, balloon catheters, metallic stents. Accounts for 0.2 to 0.4% of coronary angioplasty, and the mortality is 5 to 10% in the short term. This could be basically a large vessel perforation, a distal vessel perforation, or a collateral perforation. Large vessel perforations are usually due to oversized balloons and stents, high inflation pressures, calcified lesions that have been inadequately prepared, inadequately modified, and when one uses calcium modification tools like rotablation and IVL. Distal perforations are usually wire perforations, and 90% of these are by polymer jacketed wires. Collateral vessel perforation is during a retrograde approach. Up to 10% of retrograde cases might have some kind of collateral perforation. That is a whole different presentation, which we're not really going to deal with today. We just deal with the first two situations. Chamber perforations can occur during various structural interventions. The LA appendage can be ruptured during a BMV, during an LA appendage occluder, during so many transeptal procedures that we do. The LV can be ruptured during a TAVR or during other paravalvular closures, etc. The RA can be ruptured by a pace from anything as simple as a pacemaker wire to somebody trying to do a micra. The RV can be ruptured by a pacemaker wire or by many other tools which are used. This is the modified Ellis classification that we all know. The type 1 is the extraluminal crater with no linear contrast extravasation that suggests just dissection. The type 2 is the myocardial or pericardial plush with an orifice of less than 1 millimeter. The type 3, which is most easily seen, is a frank contrast medium extravasation into the pericardium through an orifice that is greater than 1 millimeter in diameter. And type 4 is a contrast is perforation with contrast extravasation directly into the left ventricle, to the coronary sinus, or to some other vascular chamber except the pericardium. Our data is, except for one study, the total number of published cases is less than 1,000, and the largest published series is of 124 perforations. So generalizations are very difficult because this is not a very, very common situation. However, some important risk factors have been identified, and these are the studies from where we get our data from. If we look at perforations from 2006 to 2013, you see that the 30-day mortality has remained essentially unchanged between 8 to 12%, 8 to 15%, worst in 2012. And in another study, this is the incidence of perforation, which has remained almost similar between 0.8, around 0.8% or so to 1% or so from 2014 to 2019. That means in spite of all kinds of advances of coronary devices being used in all kinds of procedures, our perforation risk has essentially remained unchanged. The risk factors are female gender, the history of COPD, chronic total occlusions, use of rotablation, and now we should add other calcium modifying tools as well, and presence of complex lesions. Coronary perforation accounts for 14% of all perforations known. About 3% of them occur even after surgical repair. And large analyses have shown that actually Cunting balloon is associated with lesser perforation than with the conventional non-compliant balloons going up to high pressures. This is the mortality, a follow-up study of 150 perforations over 10 years. And if you see unrecognized coronary artery perforation, which is 37%, this has a fairly high mortality. Even the presence of a covered stent does not protect you from mortality. And the 1-year mortality of even patients with covered stents is fairly high, up to 30%. So this is a figure that we must look at very, very carefully. But this is actually skewed by the fact that only the worst perforations get used where covered stents get used. The smaller perforations are closed by other means, if they're stratified with respect to treatment. Coils, fat embolism, and conservative management, etc. They have coils and fat embolism actually have the lowest mortality because they're usually very, very small, and these are only used for wire perforation. So they're obviously lesser on the risk scale. All these others, that is balloon inflation, covered stent use, etc., are reserved for much larger or type 3, that means more than 1 millimeter perforations. Perforations from 14 to 19 in this study, large study, in 10,278 PCIs was about 70 of them. 30% of these had undergone CABG earlier. And the mortality in 1, 2, and 3 was 14. The incidence was 14%, 50%, and 36%, 1, 2, and 3. 73% of them were large vessel, 23% were distal vessel, and 4% were collateral perforations in this study. Consequences wise, although class 1, 90% of them, nothing happened, but there was a 10% mortality in Ellis class 1 as well. So this is by no means benign. Class 2 had a 51.4% of incidence of nothing happening, although the mortality was low. The other complications of tamponades, arrhythmias, ventricular fibrillation were significantly highest with the class 3 group. What about chronic total occlusions? Amongst 2,097 CTO PCIs over 5 years from 2012 to 17, there was a 4.1% risk of perforation of that accounted for 85 of these, and 52% of them were Ellis type 3. The odds ratio for a peri-procedural MACE along with the perforation went up 15 times. So this is not at all benign, and it is best to prevent it or try and see that it doesn't occur before it actually does. The IGO CTO risk score between the two groups was 3 versus 2.5, and the patient risk factors were age, previous PCI, RCA target CTO, blunt or no stump, the use of ADR, dissection and re-entry, and the use of retrograde approach. Often with CTO guide wires, like this patient, Ramesh, a 62-year-old male, non-diabetic, old inferior wall MI, post-PCI to RCA, now CSA2, TMT positive. He had a mid RCS LED CTO after large diagonal that was filling antegradely as well as retrogradely from grade 2 collaterals and a patent RCS stent, but a little tortuous LED. This is what his LED retrograde was like. It's not a great target, but it was felt that it is still worth trying. Antegrade. The LED was not very large. So this showed a mid LED CTO, and then an attempt was made to try and cross it with the CTO wire. And you can see that the wire is definitely subintimal. And when injection was given antegrade, it's obviously subintimal. So the wire was pulled back, the heparin was reversed, and the patient was observed in the post-angial, post-cath room. And sure enough, he had hypotension and tamponade. A pericardiocentesis was done. Now, this is a problem because the wire is exited from the proximal segment of the CTO. The graft master was then delivered from the proximal LED into the diagonal. It was closed as a bailout, and that was the final result. And the perforation sealed, and the patient could be taken off the table. The use of gel foam to close coronary wire perforations is an important technique, and this is just an example of the same. We use balloon inflation to maintain a tamponade and then put in gel foam through a fine cross microcatheter into the distal circulation. This is a technique which can easily be done by everybody. Gel foam is available in every OT, everywhere. It's a small little packet of gel foam. You can take out tiny particles of it and make it into a kind of a gel with contrast. Mix it with contrast inside a bowl outside. Use a 3-way with 2.5 ml syringes. Agitate them. Put the microcatheter where you want. Inflate a balloon proximal to that so that there is no chance of reflux of that gel foam. Inject little contrast. Ensure through the microcatheter. Ensure you're in the right place. And then inject what gel foam solution you have prepared through that. And that will close it off. This is what I mean. Saline and contrast with a 3-way and another 2 ml Luer lock. Create it from here. Cut the gel foam into tiny pieces. Make it with contrast. And then you can inject this through a fine cross microcatheter into where you want. It's very, very simple and extremely effective. Often it is said that IVL does not perforate. This is not at all true. And IVL does perforate. This is, it's not that it doesn't. It's just that one has to be careful. Choose the correct size balloon, neither oversized nor undersized, the adequate size of the correct size balloon, and use the right technique to try and ablate or modify the calcium, especially if it is concentric and if the balloon is in the junction between the calcified and the non-calcified part. What about long-term outcome of different covered stents? There are 29 studies reporting 725 patients, and the mortality was 17.2% with a MACE of 35.3, with tamponade in about a third, and 5.3% going for emergency surgery, which has a horrible outcome usually. What happened to our cases? This is our first perforation. We'll go back to where we started from. The first step is balloon tamponade. Balloon is taken, inflated, and then you check to make sure that we have stopped the leak. Gives you a little time to think and plan what you want to do. Ideal thing is to take a second guide, second puncture, put in a wire, deflate the balloon and wire the display LED beside this balloon, and then inflate the balloon again by the ping pong technique. And then one can position the covered stent, deploy it, post dilate it well, This patient, remember, had a proximal lesion as well, and that was covered with the second stent, and the whole segment was post-dilated. And this was the final angiogram. We lost one diagonal, but the patient did well thereafter. This is the second case who had an LS type 3 pre-perforation, and this was extremely large, and the patient's pressure immediately dropped. It was absolutely free, and initially, first step was balloon tamponade. There was a pericardial effusion. Even in this step, you can see the difference between the outer border of the heart and the pericardium. It's quite significant even on the angiogram. After the pericardiocentesis was done, this was done to localize where the leak was. Since there was only one operator, there was no time to take a ping pong guide, and the patient was extremely unstable. But however, we were lucky enough to get the graft master into place, dilate it, position it, deploy it, and get away. This is what we started with, this is what we had in between, and this is what we ended with. Another rare example of a perforation being imaged. This was a 53-year-old chronic stable angina, class 3 smoker, dyslipidemia, and this was his right coronary artery angiogram. This was in the days of the BVS, and we were obsessive about pre-dilating and post-dilating the BVS well with imaging. And this was a mid-RCS subtotal occlusion. And after the balloon dilatation with a 330 NC, and you see a small dissection, but it is not something that is really worrying for anybody. We just thought, all right, we will take a BVS. This is the stent being positioned. And remember, this is an extremely old study of, 6 years ago when the BVS was being used, and we were part of the initial trials for it to be used. This is the positioning of the BVS, and that's the deployment of the BVS, the post-dilatation, and then the OCT was done. So as the OCT comes in, you can see the distal part seems all right. It's well in contact, but as we come in within the stent, you can see the stent completely loses contact with the vessel wall and is actually floating inside the vessel. And you can see a little break at about 2 o'clock or so. That's not the wire artifact, which is around 3 o'clock. And in this, again, there is a little bit of crowding here, which means that it needs to be post-dilated a little bit. And the rest of the proximal stent was fine. So for the sake of brevity, I will move forward. Should I play it again?
No, sir.
Maybe just the part which shows the perforation, sir. If you can pause it
So
there.
you can see this. I'll see if I can pause it. Here, you can see
That's
this break.
Yeah.
You can see this break here. I don't know if you can appreciate. I'll just show it again. You can see this break here.
So the way to differentiate it from the intimal dissection, which we can see it at around 7 to 9 o'clock, how would that be, sir? In the same,
It will be on the angiogram.
Yeah.
You can see a separation between the strut and the vessel wall, and you can see a break in the vessel wall continuity. Now, this was with the maximum depth of the OCT in those days. This was the older catheter before the newer catheter came, and we actually didn't know how to recognize it at that time. But we did an angiogram. We thought we'll post-dilate the vessel a little more and went in with a bigger balloon and tried and post-dilated with 4. And we realized that we'll actually worsen the situation because the separation became even more. And that you can see in the second image from the left side of your screen. You can see the separation has become more. And when we took the angiogram, this is what we found. So, and you can see that this was a huge hematoma into the right ventricular wall, and now we're between a rock and a hard place because we are stuck with a BVS, which has caused a perforation and is very difficult to exclude. So after a quick conference, we decided that we'll have to cover it with 2 covered stents, and that's what we did. So first we balloon tamponaded it, just checked that the balloon tamponade was functioning, then measured the length, and then put 2 covered stents, and then did an angiogram after that, and the leak has sealed. We brought the patient back to the table after 8 weeks and then did another angiogram, and this is what we found. It looks perfectly all right. And we left it alone after that. So this is another, we found a case report of something similar, of a mid-LED perforation on OCT. This is not our case, but somebody else had tried to do the same thing and they ended up with a similar result. But it's in the same segment that I keep emphasizing is very often intramyocardial, and one must not always chase a little bit of under expansion here. You try and over expand it, you'll end up with a massive perforation. This is another answer for people for sometimes when you don't have a covered stent. What we can do. This is a 56-year-old male with hypertension and dyslipidemia with chronic stable angina, recent worsening, and exertion distance of 200 meters. He refused bypass surgery for some, sometimes you really curse why you have become an interventional cardiologist, and this is one of those occasions. This is what his angiogram was like. And we did a nice DK crash left main bifurcation. We'll not go through all the steps of that, but suffice it to say that the result was very nice and very pleasing. And then we looked at his right coronary artery to the four-dominant vessel with a short segment CTO. And there's a small PD coming from here. So we decided we'll try and open this. With great difficulty, we managed to put a wire through. So the what staining you see on the top is there in the left injection even before um, the wire goes. So we were not worried about that. But distally, we felt that it looks all right, but there is some extravasation here. We weren't sure whether it's a dissection. But then patient by this time had been on the table for a while and he gave a massive retch and he pulled out the whole system. And this is what we ended with. Entire assembly popped out and there is an ugly perforation there. So initially we did a balloon occlusion of the proximal RCA into the sinus nodal branch, but we needed that vessel to go because he started having loss of P waves and bradycardia. So we thought we'll wait and see. Probably it'll come back. We waited. It didn't come back. So we knew that we have got to revascularize this vessel. So this size covered stent was not available on the shelf at that time. This is also an old case of 2015. So we fashioned the covered stent. We have taken a 2.25 stent, cut a 2 millimeter balloon, sleeved that balloon over the stent, opened another stent, deployed it outside, and sandwiched the 2 millimeter balloon between these two stents and hand crimped the second stent onto the first stent with the balloon in between and created a covered stent. And that is what it looks like. And then stented that segment into the sinus node artery. And
So you need to repeat this a bit slowly.
So you need for this two stents and one balloon. So one stent is left as it is. You choose the inner stent to be 1:1 with the size of the vessel you want to close. Then you choose a balloon which is 0.8 or 1:1 of the size of the vessel. And you inflate the balloon outside and you use a blade to slice off a sleeve of the balloon. Once the sleeve of the balloon is sliced off, that sleeve is now pushed onto this stent, left there. Now you take another stent of the same size or slightly shorter. I mean, if you're taking a 20, you should take an 18, second one, and inflate that stent outside. Then take that stent off the balloon. Now you put this stent on top of this balloon. So now there is a stent, on that there is a balloon, and on that there is another stent, and you hand crimp it. You hand crimp it onto this. You can also take a silk thread, ravel it around, and then unravel it. It kind of fixes it very, very well. This works in proximal circulations if you're very badly stuck and you don't have a covered stent in a desperate situation. That's why I show it, because sometimes it gets you out of trouble. Is that understood?
In case anyone else wants it repeated again.
It's something like a Joe stent, but made by hand.
Exactly.
Yeah.
Made by hand. In fact, the Graft Master is nothing but a sandwich stent like this. It is just a mesh with two stents, and it's made in exactly the same way, only it is made by machine. What I'm saying is it can be done by hand and it will get you out of trouble sometimes.
The diameter of both the stents are same, only the length is different.
Yeah, so you must ensure that the inner stent is either the same diameter or slightly larger so that it is able to oppose perfectly against the wall. And same thing for the balloon, that it must either be the same size or slightly smaller so that it doesn't leave too much of space in between the stent and the balloon. This is what it looks like. It doesn't look very nice, but it does the job. In summary, perforation is a dreaded complication, especially type 3. The important thing to remember is immediately balloon tamponade it. Pericardiocentesis is an important skill that every cardiologist must have access to. It's a good idea to train yourself and rehearse in your mind how you're going to do pericardiocentesis, especially in obese patients with bad anatomies that you're going to put on the table. Covered stents must always be handy. Gel foam, microcoils, and fat are other options for wire perforations. They're not meant for major perforations greater than 1 millimeter, that is Ellis type 3 perforations. This is what algorithm would look like. We do a prolonged balloon inflation. If there is evidence of continued contrast extravasation despite prolonged balloon inflation, we use a covered stent. If it's a distal coronary perforation or covered stent is undeliverable, prolonged balloon inflation with IVP support, coil embolization if possible, surgical repair of a perforation or CBG are the only options. The other, after placing the covered stent, if there is still evidence of continued extravasation, post dilatation of the covered stent, this is important. Covered stents are not to be deployed as 2, 4, 6, 8, 10, 12, 14, 16. You must go up slowly, about 3 atmospheres per second is the fastest, and stay at your nominal or supranominal, about 2 atmospheres higher for a long time. They take time to expand and they are not going to deflate very, very fast. So you must take time to expand them, always post dilate them wherever possible. The graft master, the whole length is not covered. About half to 1 millimeter on either edge is actually uncovered, especially when you post dilate them. So that's important to remember. It's possible that you might require a second covered stent implantation like we did in our BVS case. Prolonged balloon inflation and IBP support will often help to keep the other coronaries pated. Coil embolization, if required, in case there is still some leak, can sometimes be done. And surgical repair of perforation with or without CABG is always an option. The reversal of heparin is an oft discussed issue. There are multiple views on this. However, if you have hardware inside the coronary, it is not at all safe to reverse the heparin. It's all right to reverse the heparin once you have taken everything out. If the vessel is already gone and you're willing to sacrifice is a totally different issue. I mean, you have a small distal RCA perforation and you're not able to close it. You want to reverse the heparin, you think that's going to work, you can go ahead and do it. There are many out-of-the-box solutions. People use broken bits of wire to close wire perforations. That means they will cut off the coronary wire, put a microcatheter there, and push this broken wire through to the edge. People will use small 2.25 stents inflated at 2 atmospheres so that they just come off the balloon and they remain there. They will thrombose and close off that vessel, etc., etc. There are many innovative and different ways for dealing with difficult and tough situations. And there are many people who will completely knock off the vessel and allow it to infarct because it's easier to manage a small vessel infarct caused by a distal wire perforation than try to close it sometimes in a very, very tortuous situation. So, how do we anticipate? Careful angiogram review, and this every interventionist who has done enough procedures will realize the mid LAD or sometimes the C of the circumflex is often intramyocardial, and trying to post dilate stents without paying careful attention to the angiogram will often end up in perforations, type 3 perforations, which are very, very difficult and dangerous to manage. Liberal use of imaging, especially if there is calcification, will help you to decide what tools to use and when to stop. And careful wire manipulation, especially CTO wires and polymer jacketed wires, is mandatory before you kind of take any hardware over them. Before putting the stent in, it is important to prepare the bed extremely well, because otherwise you'll get stuck without being able to deliver hardware, and then that is a terrible situation to be in case one has a perforation. And always use only an NC balloon for post dilatation. We did see that even in our cases, the intramyocardial segment of the LAD was attempted to be dilated with a stent balloon, which is usually a very, very semi-compliant or even a compliant balloon, and goes up very rapidly. It has a very large creep, and that sometimes leads to perforation. Calcium and rotablation, it's important to pay attention to the vessel size for burr sizing. I don't exceed 0.5:1 of the vessel ever. If it's a 3 millimeter, I will not go beyond a 1.5. If it's a 4 millimeter, I will not go beyond a 2 millimeter burr. 175 is the largest that I will go to in case it's a 3.5. Vessel anatomy is important. Curves are not good for rota, and it's important to be careful and gentle with taking the rota across any curve. Wire bias is to be remembered. It will often go along the inner side, and if the calcium spur is on the opposite side, then you are stuck because you might not actually ablate the calcium and you'll end up with the burr going and exiting the architecture of the vessel. If calcium is eccentric, only on one side on the angiogram, imaging is mandatory for you to decide where the wire bias is and which side your rota burr is going to do. In our lab, we always image after the rota because sometimes before the rota, it is difficult to deliver the imaging catheter. So our strategy is to go in with the rota, image once, and then see if we have done an adequate job or whether we need to do some more. If more modification is required, you can always do more. You can cut and then go back in with the rota again, upsize the burr, use non-compliant or high pressure balloons, etc. Post dilate only with non-compliant balloons, especially in calcified lesions. Thank you for your attention, and I should be glad to answer any questions. I'm sorry it was a lot of theory, but was my brief for today.
I think one thing is very clear that if you, as you very highly suggested, that once if you have a hardware inside, no protamine. So that's pretty clear. So if you implanted a stent and landed up with a perforation, no protamine. That has to be, I think, because there's some confusion.
No,
The
no,
other
no.
thing,
If you have a stent and you can reverse protamine as long as you do not have hardware still in the coronary. You can, if
okay.
you have put in a stent and you are sure that you've done a balloon tamponade and your tamponade has stopped, or you feel it's a wire perforation, it's a small perforation, you feel that reversing the protamine is going to stop the leak. Once your hardware is out of the coronary, there is no problem. The stent is not going to thrombose. It is only the only rider is as long as you have hardware inside the coronary. That means something that is still there, not a stent, but something that's still there. At that time, it is dangerous to reverse it because you can end up with thrombosis on the wire, on the balloon, etc.
So the second thing is we often use cutting balloons to modify calcify plaque. So what is more important in cutting balloons? So the length of duration of inflation, or is it the higher pressure at which it has to be inflated? For example, if you're using Flextome or Wolverine, which of it is more important? So non-compliant, we go very high. We go up to 18, we go up to 20, and then we deflate. But is it the same for a cutting balloon? Do we go higher pressures, or is it low pressures and prolonged inflation?
So the Wolverine balloon is actually mounted on the non-compliant balloon. That is the
Yes.
NC Emerge. And although it is nominal is 6 and the RBP is 12, you can actually happily go up to 18 as long as you don't exceed the size of the vessel. If it's a 3 mm vessel, don't take a 3.5 cutting balloon and go to 18. You can take a 2.5 and go to 18 happily. You can take a 3 and go up to 14, 15, 16 happily. There is no problem. There is no contraindication to going high pressure with the cutting balloon as long as the size of your balloon is fine because it's mounted on a non-compliant balloon. Unlike the angioscalp, which is mounted on a compliant balloon, although they say RBP is much higher, it actually doesn't expand the way in which you want it. It will expand everywhere else except where you need it to expand. So there's a basic difference in philosophy. If you see Antonio Colombo, he does not stop. Of course, I'm not advocating that everybody do this, but he doesn't stop with the cutting balloon till he goes to 20 atmospheres. And in our lab, we are fairly liberal with the high pressure inflation as far with the cutting balloon, especially with the Wolverine because as I said, it's mounted on a non-compliant balloon. So it doesn't increase in size very much. The only fear from the company is that the cutting balloon blades will shear off if you go very, very high pressure. So what we do is we go very slowly. That you go up to 6 atmospheres, you know, at reasonable speed. From there, you don't go more than 2 atmospheres per second. And apart after 12, you don't go faster than 1 atmosphere every 2 seconds. That means you go very, very slowly. Another tip for the cutting balloon is once you have delivered it, deflate it, bring it back, rotate the hub by about 45 degrees and go back in again so that your blades now get oriented in a slightly different fashion and the ring of calcium or the ring of fibrotic tissue that is there gets weakened at multiple places. That makes it easier for you to get a good expansion.
So how about the size of the covered stent? How would you
Pardon
choose
me,
the
sir?
size of the covered stent, the diameter of the covered stent?
So covered stents actually come only in two sizes. If you're
They
looking
have
at
some
graft
funny
plastic,
sizes, 2.8 and such sizes are there.
so these are only the balloons on which they're mounted, sir. They actually come only in two sizes. And you can go with the 2.8 to 3.5 up to 3.5, but it's important to choose the larger size for the larger cover stent because obviously you want as good a seal as possible. They actually come only in two sizes. The change in size is only the balloon. Stent is only manufactured in those two sizes.
Sir, good evening. Sorry I joined late.
खत्म हो गया यार.
हाँ जब तक मैं ज्वाइन करता हूँ सब
क्या करें.
YouTube में देखना पड़ेगा.
हाँ नहीं कोई बात नहीं. You can see it again. I will run through the slides. मैंने basically ये दिखाना था that dissection is possible. Rota is possible in dissection. So I chose the dirtiest example to show, and I think if anybody else is there who wants me to show that particular case again, I can do it again. Rest of the perforation is all theory which everybody has seen. I just tried to show some case examples and some ways to close.
Sir,
Bali
catch up with the YouTube. अभी YouTube में 2-3 दिन में अपलोड हो ही जाएगा.
हाँ बस no problem. As you wish. जैसा आपको.
बाकी लोग बोल रहे हैं.
Sir, nice cases, sir. I just want to know, sir, which wire you have used in the case in which you have the mid LED perforation. Because I never seen the perforations due to the CTO wires. Most of the wires goes outside the pericardium, and they never cause the perforation like Alice type T in your case. I just want to know about that.
I think that was it wasn't I was the one doing the rescuing. The wire was a Gaia second.
Okay.
And you had to work very hard to put it in the position where the operated head, but he managed it. Actually, they kept seeing only one view, and they kept advancing the wire, and it had gone not only through, it had cut through the septum and gone into the lateral wall. Okay. And that's where the problem is. If you rupture a septal, most of the time it will forgive you, but the lateral wall doesn't.
Okay.
So
I also had a perforation today, sir, but that was a femoral.
All right.
Yesterday we did a TAVI, so it was borderline femoral around 4.5.
Okay.
We gradually dilated, and then I learned a new trick that you smear propofol over the
propofol.
Yeah.
No, it's very, very, very good trick. And we used to use it for all our aortic stent grafts. It works like a charm.
So everything went well. Morning, that patient had tachycardia. Early morning today. So nothing wrong, no pain, nothing, no pain in legs, nothing. So I was just wondering why he had tachycardia. Then he palpated his dorsalis. It was absent. And took him for ballooning. After ballooning, he had dissection, and then he had a perf. So ultimately, had to send
Actually,
it to...
if you could have put a covered stent. Which part of the vessel perforated?
Sir, it was above the femoral head, and he had problem. A lot of thrombus at femoral head also.
Okay.
And then I just had one perglide, so the other I usually apply two. Other one broke before I could apply. The suture was cut, so I had one. So we did a angioseal, one perglide, and manual compression. So morning, as soon as I did the this dilatation, the excess site started oozing.
So I'll tell you one thing. A lot of people are using a single proglide for 14 French and compressing it. They don't put a second proglide. They don't put an angioseal.
Sir,
a single one.
Yeah.
And they don't put an angioseal. They just compress it.
Two TAVIs yesterday. So the first case, we had right excess again 14, and then we lost the wire after deploying the stent. And while recrossing, after deploying the wall, we lost the wire. The wire came out as soon as we deployed the wall. It was wall-in-wall TAVI.
Okay.
And then we had to recross. Recrossing, we crossed through the struts. Then I tried to make sure that I have not crossed to the strut. I passed a balloon. That balloon got stuck into the struts.
Okay.
So I went to the left side, put another 14, then crossed this wall, balloon dilated. This time again I was through struts.
Okay.
So I had to embolize that, bring it to the...
Why are you asking me to show some boring cases? Why don't you show these exciting things?
I'll show you, sir. Next time.
So your boring cases are more common than these exciting cases.
Right.
I'm still
In case,
in learning steps, sir. So, it's always, this
no,
is a
vascular complication is
master's
a
class, sir.
major.
It is not a student's class.
What nonsense! Everybody is a student here.
Mhm.
That is all. That's not fair.
So can I ask one question?
Yeah, yeah.
So, like sir, you were mentioning in eccentric calcium, if the calcium is eccentric, we should do an imaging and see whether the rotawire is towards the side of the nodule and not away from the side of the nodule.
Correct.
So can we be really sure that when we are actually rotablating after we have taken the imaging catheter out, it will still stay in the same position and not migrate to the other part? Like when
So
you
how
take
we
out the
image
imaging.
with the wire, Saujatya. We don't put the rota wire beside it. We first image with the wire. That wire itself, majority of the time, will tell you what route the rota wire is going to take. The judgment is when your original wires, you see which side the wire artifact is coming. Is the artifact on the side of the calcium or is the artifact on the normal side? That is the route, the same route that the rota wire will take. But you can modify
Okay.
that by after doing that, you can then do a cutting balloon at say 10 or 12 atmospheres and then go back in with your rota wire and then do another burring because that will modify the bias a little bit. It will shave off a little bit of the calcium and make it slightly easier to manage.
Right.
This one I just wanted to show again for anybody who came in late. This is how, rotablation in extreme dissection. This was an oscillatory lesion. You can see a little bit of calcium in the left side. So we crossed it, balloon dilated it, thought we'll do an LM-LED crossover, but the stent wasn't going and you can see some dissection there. So a little more aggressive balloon dilatation was started and you can see big trouble now. The entire LED is dissected and the circumflex is shutting down. I'm just showing this because to show this is the most extreme example of rotablation in dissection. So now this is where we are stuck. What do? Do we send the patient to surgery? We put an anchoring balloon and cross with the balloon. It was told dissection is a contraindication and we'd have to lose the circumflex, but still we made the decision to go ahead. We first put in an IABP, got the anesthesia and the inotropes back on board, tried with a bigger balloon, wouldn't go. And then after that, managed to deliver the rota burr, put in a microcatheter, put in the rota wire and did not pull out the circumflex wire until the rota burr was at the mouth of the left main, burred through the LM LED part and into the proximal LED. And now this time the corsair could be repositioned very easily, whereas it went with great difficulty initially. It just walked through and then finished with a DK crush. I just wanted to show this because there was some discussion that dissection is a contraindication to rota, and it was a much more detailed discussion last time. So we also spoke about perforations, the major vessel perforations, the wire perforations, and the collateral perforations. And I said collateral perforations, that's a whole presentation in itself. So that really can't be covered in these 15 minutes, so half or 20 minutes. So if there are any questions, I should be glad to answer.
Ajay, excellent. Can you hear me?
Yes, sir. Good evening. I was waiting for you all evening.
I joined a little late, but it was an excellent lecture as always. I would talk about perforation. The only point I want you to comment on is that many times when perforation occurs, a lot of time is lost in deciding whether to take a stent graft or not. And during that time, a hematoma may appear in the vessel, and there may be extraneous pressure on the vessel itself. And even when you get a stent graft across, you may not be able to establish the blood flow and the vessel may get infected. The area may get infected. So the decision to put in a stent graft must be rapid. And after you've done a ping pong, the first thing should be get a 7 French in the femoral, get a ping pong and get the stent graft early. Too much time must not be said that, infecting the balloon and probably will take care of it. And there should be a rapid thing. The other thing which I wanted you to comment on is that the dangerous perforation which I've seen is in the left main bifurcation. And there if you put in a stent graft, it occludes the circumflex, and there are case reports where you can perforate that with a CTO wire and go into the circumflex and finish the procedure. You have had any such experience of, opening up a stand graft and going into an occluded vessel after you put in a stand graft? Only one comment I would like.
So it's the first part in one of the cases I showed that, in fact, we were so quick that we did not even allow tamponade to occur. The moment the perforation occurred, the balloon was back in. We had a ping pong guide. We just deflated the balloon, put in the wire, made the decision. We did not allow tamponade to occur. The second patient whose perforation I showed was actually a very, very large and a free perforation. The moment it occurred, the patient just crashed. We managed to put in the balloon and do a balloon tamponade straight away. The only delay was in getting the, pericardial drain in position. That was the 5 minutes that it took. And we didn't, since I was operating alone that day, I did not have time for a ping pong as well. Since I was confident that we had dilated well, we managed to put in and take it out. And it was all done in a matter. But the point is extremely important and very well taken. You must make very, very quick decisions. And it is better to do something early rather than decide at the end of 20 minutes that nothing can be done. A lot of people say we put a balloon tamponade and wait. That is not true for an Ellis type 3. No Ellis type 3 is going to close on its own unless it is actively closed, because it is operating against arterial pressure and the leak will continue. In fact, wire perforations as well, I would recommend that you make the decision early to close them. Otherwise, you come back and then you keep waiting 4 to 6 hours later and then hope that the seal gets closed and it will not close, and it will close, it will not close, etc., etc. You must make the decision early. That's a great point. I have never perforated a left main in the dramatic fashion that you described. And I hope that in this lifetime, I don't have to do it. But I have seen a demonstration of that in a live case done by somebody outside. We actually tried to perforate a graft master ourselves with a CTO wire. What I did find outside, because this I did for my interest, the kind of hole that you create is rather ragged. And you don't always end up with a perfectly circular hole. And you're very much dependent on the good Lord above to try and get a perfect seal, even if you manage to deliver a second covered graft stent. So I think it's best to try and avoid situations where, we have to kind of forecast or kind of try and predict the situation in which it will occur. And I mean, there's no better person than you to say it. But as I said, I tried to perforate.
No, I have not done it. I have not done it, but I've seen cases being done like that.
Yes, the same here. I don't want to do it also. I'm very happy seeing them. Let it happen to somebody else. But I tried to perforate the graft stent on my own with a CTO wire outside. As I said, the kind of hole that they produce is very ragged. If you see, when we do fenestration for the aortic stent grafts also, when we make a hole with a laser or with a cautery or whatever, you must seal that with what we usually use is a Fielder XT or an XTR, the black part, and seal that with, we use magnifying glasses and try and seal that hole. Because even if you don't, even when you put in a covered balloon expandable stent inside that when you make what's it called? Fenestration. When you make a fenestration, sometimes it expands unpredictably and it causes a linear tear in the graft, and then you end up with a leak again. So it's not a very, predictable thing to be able to. You may be able to perforate it, but the kind of hole that one will create is not always predictable. That is the only comment I have.
Another comment is that when we are doing this stent in a calcified lesion, which are the most likely to rupture, you may not have prepared the bed before the perforation has already occurred. The good point is that you go ahead, whether there is a high pressure balloon dilatation or a rotablator or whatever, means even cutting balloon or whatever, it will increase, the perforation would increase. But you need to get that bed prepared to get your stent graft into that. So instead of panicking, go up more aggressively at tackling those calcified lesions so that you can get the stent graft across that area.
Yes, sir, we did have the discussion probably just before you came, and I said that in case you have a perforation before a rotablation, first thing to do is go ahead and finish the rotablation so that you can get your hardware across. We did discuss that point, and Rahul had mentioned it. And I said, you must go ahead and finish the case. You cannot leave it halfway. You'll not be able to deliver any hardware, and it's a nightmare to try and do something after that. No surgeon is ever going to bail you out. You have to do it yourself.
Yeah, absolutely. Great.
Dr. Swami, great talk.
Sir, thank
Any
you. Good
comments
evening.
about any comments about venous graft perforations? How to tackle, how frequently is it?
So vein graft perforations are actually, they give you a little bit of time, and there is a misconception that vein graft perforations or patients who are post CABG do not develop tamponade. This is false. This is not correct, and I have seen patients being suffering because of this misconception. The only thing is that if it is a vein graft perforation which is far away from from the heart, the patient will bleed into the mediastinum and cause a large mediastinal hematoma. It's important to diagnose these early and to seal them as fast as possible so that you minimize the effect, because mediastinitis is a very, very ugly entity to manage. I've had two patients like that over the last 10 years. God was kind and we were able to deliver covered stents in both of them. Although in one we had to take a mother and child with an MPS 6 catheter beyond the perforation to be able to deliver the graft master. But that is something which has to be done. We didn't have the this is in the days before the guideliners were available, and we had to shorten the sheath and then put one guide inside the other, and then deliver the graft master, because that is all that was available. But we managed to do it, and it's not that it does not occur. And we have done rotablation in vein grafts as well. Sometimes that's also required, and I feel that if there is good amount of calcium, it's probably safer to try and do a rotablation than to try and do a high pressure balloon dilatation. Sometimes, if you have concentric calcium.
Yeah, this venous graft rupture, it can cause mediastinal hematoma, one thing. Other than that, it can cause a localized pressure on one of the chambers of the heart, which may be impossible to diagnose unless you do a CT. And to see that, you may have what we call the dry tamponade or whatever.
Tamponade,
so it is
dry tamponade.
very difficult to diagnose. Patient will just have hypertension, so you need to diagnose that early. So that concept should not be there, that if there is no pericardium,
Cause, yes. Yeah, absolutely. Absolutely. Especially the RCA is very, very, very notorious, and vein graft for the RCA is very notorious. It must be absolutely right, sir.
And sir, is this the reason for not to attempt the chronic SVG graft PCIs, as the risks are more in SVG PCIs?
No, I don't think it's a risk of perforation so much, Saurabh. I think it is about having a beautifully patent epicardial vessel, but absolutely no microvascular flow that prevents people from trying to open chronically occluded vein graft, vein graft. Having said that, there are several studies in which they actually opened them, but they didn't find any benefit because the amount of embolization was so much that you ended up, as I said, with a good epicardial vessel, but no microvascular flow. But sometimes it's important to be not to be so negative. And if if the house gives me permission, I will show one case in the next month in which I have opened a completely occluded vein graft because there was no other option. This was a 72-year-old who had undergone a bypass surgery about 16 years ago. He came in shock, and his left circulation was completely occluded after the first septal, and right circulation was completely occluded after the ostial RCA. We had no idea of the graft. 2 o'clock in the morning, we just picked up a retrograde flow from the LAD into one vein graft, and we realized that that was the only access. And when we opened that vein graft, we found that the entire left LAD, circumflex, and the RCA were dependent on that vessel. And it was quite a dramatic save. So it's not like it doesn't work. The reason why they don't do, again, I emphasize, chronically occluded vein grafts is that the amount of embolization is so much that you don't end up with any significant myocardial salvage. But acutely occluded vein grafts can definitely be opened with good benefit for the patient.
Thank you, sir.
We can have it in February, sir. January, I wish that we do our traditional honoring our
Yeah, absolutely.
So there also I'll need your help. We'll need to trace out the later batches. I think these would be later batches, so easier to trace them.
Yes, definitely.
And one is Dr. Mandeep Bhargav is also planned for a 3D EP ablation.
Okay, great.
That is one class which is pending. But I have not contacted him for last 2 months. He said that he'll be traveling, so it would be January, February. So we can have it anytime. We can have it at India Live.
Yeah, sure. No, it's a
You can
2-minute
have
case. It's just
it
to
at
show,
India
because
Live
the question
daily
was
notes.
asked. I said it's not at
Sir,
all.
it's
My goodness.
sir,
It's just to show, nothing else.
for me, it's difficult to get people to come forward, sir. And cases to come.
No.
And Sumi sir,
I think
one class in CRTD, difficult CRTD implantation, LV lead placement, if someone can tell us.
yes, sir. Yeah, bilkul. Smith, he wants somebody to take a class. Get Vadivel or somebody to speak. Yeah, one of the EP guys to speak on LV leads.
Yes.
Thank you, sir.
So my request would be you put this request in the group.
Yeah,
So
absolutely.
that people can volunteer, because if you do have, like, I must, but I'm sure that today's cases must be excellent cases. So it only came out because I think last time I was showing some dissection, and then sir said ki rota can be done in dissection, and that is how.
Me and my big mouth.
So you are in control, sir. I have no idea about today's class.
Kuch bhi nahi, khatam ho gaya. It's nothing. It's just theory discussion on perforation. I showed the. If anybody has any questions, I should be glad to answer. But we discussed first the case of dissection, and then I showed some perforations and imaging in a perforation, and situations of different ways of managing. I mean, how to put a covered graft stent, quick this one, and then how to close a wire perforation. What I use is usually gel foam because it's the most friendly thing to use. Other people use bits of wire, fat, etc., coil, etc. And whatever, it's important to plan for these and prepare for them before they occur, so that you're not caught napping and suddenly somewhere. So it's best is to have a kit ready and to have the hardware ready and to know how to do it, so that when you're actually called upon to do it, there is no at that time you don't hunt.
You're concentrating on the case rather than arranging for the hardware.
Absolutely.
That is worse.
So I think we are at what, 9:50? Not bad. 8 o'clock to 9:15 is good. Yeah.
So yeah, that is our usual 8 to 9:30 is our usual time. So.
Yeah.
Saujatya is in new looks.
Vichara. We'll talk about it offline.
Right.
Bali sir, anything you want to say? Shastri sir?
No, I think excellent talk. Now I enjoyed every bit of it. It was masterclass, absolute masterclass. More power to you.
Thank you. We are pygmies on the shoulders of giants, our teachers.
You are a stalwart.
No, sir. Yes.
Great. Look forward to hearing more from you.
So I'll post, sir, those we need to trace. I think we'll, if there are around 5, 6, so we can have it from one batch, 1 year.
Yeah,
we'll
do that.
Right, sir. Right.
Thank you, sir. Thank you so much, sir.
As always, 3 cheers for Smit. Hip hip hooray.
Thank you, sir.
Thank you, sir. Thank you, Ajay, sir.
Thank you.
Thank you.
Good night, sir.
Thank you, sir. Shastri sir, any last words?
You are the master there.
Right.
Right. Good night. Thank you.
Thank you. Good night, sir. Thank you, sir. Good night, sir.